Hi, it's Dr. Terry. Today we're going to be talking about schizophrenia spectrum and other psychotic disorders. This lecture is primarily designed to accompany the pre-work for a team-based learning activity for second-year osteopathic medical students. However, your uses may vary. We have 10 learning objectives we hope to cover today. First, we'll be contrasting the serotonin, dopamine, and glutamate hypotheses of schizophrenia. We'll talk about the role genetics play in the likelihood of developing thought disorders, differentiate between 3 categories of symptoms seen in schizophrenia. We'll talk about individualized treatment plans for patients with schizophrenia. We'll evaluate options for individuals with treatment-resistant schizophrenia. We'll compare the potential advantages and disadvantages of antipsychotic polypharmacy with an emphasis on typical versus atypical antipsychotic medications. We'll talk about the mechanism of action of first-generation antipsychotics as well as those of second-generation antipsychotics. We'll compare and contrast side effect profiles of individual antipsychotics, and then we'll also evaluate options for patients with schizophrenia who are taking medications for other disorders. In common language, people often confuse the words psychosis and schizophrenia. Psychosis, from here on forward and throughout this conversation, should be considered a condition or a set of symptoms that affects the way the brain processes information. It can be seen as a detachment from reality. It may be a symptom or a secondary effect of sleep deprivation, substance use, mental illness, or other conditions. Psychosis typically includes hallucinations, delusions, agitation, and/or disorganized thoughts or behavior. This is different than schizophrenia, brief psychotic disorder, and schizophreniform disorder, which we'll discuss more on the upcoming slides. The takeaway for the learner here is that psychosis is a symptom. It's not an illness, and for the most part, it's not a diagnosis, even though there are diagnostic codes that correspond with it. Psychosis may be in many different conditions, ranging from mood disorders to thought disorders to personality disorders, delirium, post-traumatic stress disorder, metabolic disturbances, and many other conditions. Over the next several slides, we'll be talking about types of diagnosable psychosis, including brief psychotic disorder, schizophreniform disorder, and schizophrenia. For the learner, these can be thought as having very similar symptoms, but the key difference here is how long these symptoms persist. Brief psychotic disorder is in place for up to 1 month, and it's often triggered by extreme stress, such as bereavement. Symptoms must include either hallucinations, delusions, or disorganized speech. If the same symptoms are present for greater than 1 month but less than 6 months, that can be known as schizophreniform disorder. Again, the symptoms must include hallucinations, which describe perceptual disturbances, and those might be auditory, they might be visual, they might be olfactory or tactile, or much more rarely, gustatory. We'll go into much more detail about how schizophrenia is diagnosed and the key characteristics later in this conversation. Schizoaffective disorder tells us what it is if we take apart the word schiz, referring to a thought disorder or psychosis, and affective, same root as affect, referring to a person's mood. So schizoaffective disorder describes an underlying thought disorder or an underlying psychosis in which a patient also experiences mood disorders. Now, mood disorders, by definition, are going to be episodic. So, a person with schizoaffective disorder may have depressive moods, they may have manic or hypomanic moods, or they may have both. The important component of schizoaffective disorder versus, say, bipolar disorder with psychotic features is that in schizoaffective disorder, the primary disorder is psychosis. What that indicates is that the symptoms persist for the psychosis even in periods when mood symptoms are not present. You can think of this as schizophrenia, which is chronic and persistent, plus a mood disorder, which by definition is episodic. As I mentioned, this is different than a mood disorder with psychotic features, where the psychosis would only occur at the peak, such as in a manic episode, or trough, such as a depressive episode, of the mood disorder. Genetics and neurotransmitter changes are thought to be possible causes of schizoaffective disorder. Schizoaffective disorder in general also has a better prognosis than schizophrenia. On the last slide, I mentioned bipolar disorder, And bipolar disorder is something that we can think of as a mood disorder primarily. It's not a thought disorder. A mood disorder is synonymous with an affective disorder. Bipolar disorder is characterized by cyclic changes between extreme highs, such as mania or hypomania, and lows, such as depression. We'll be talking much more about this in a subsequent TBL. Now, as I mentioned, symptoms of psychosis are hallucinations, are delusions, are disorganized speech or disorganized behavior. Those may occur during the manic or depressive episodes, and a person might experience a combination of hallucinations and delusions or other psychotic symptoms. A key point for the learner is to really differentiate and understand the difference between, say, schizoaffective disorder, bipolar type, and bipolar disorder with psychotic features. Remember, the schizoaffective disorder is primarily a thought disorder, and it's going to have severe and persistent symptoms, whereas the mood disorder or the affective disorder is by definition going to be much more episodic, and the psychosis is only going to occur when that person is in the midst of a mood episode, whether it be depressed, manic, or hypomanic. No discussion on psychosis is complete without discussing a definition of delusions, and of course, therefore, delusional disorder. We should understand that delusions are fixed and false beliefs. It's when a person has a belief system that would not be easily echoed by someone around them, by others, say, in the exam room. It should also be noted that, say, religious beliefs, political beliefs, areas in which we might disagree with a person don't necessarily mean the person is delusional. Delusions are something that are often much more unique to a person, and in saying that they're fixed and false, you're not going to persuade someone or do enough therapy to get them away from their delusion. For our purposes, as second-year osteopathic medical students, delusions are fixed. They're not going to be changing. Types of delusions may include grandiose delusions, where a person believes that they are much more valuable, or have certain skills, or have certain appearances, or different personal factors that may not be true. Persecutory delusions involve a person who believes someone is after them, either for a reason or just in general. Erotomanic delusions can include being loved by a famous person or someone who's way out of their league. Somatic delusions can have to do with body problems. A person might believe that they are pregnant, that they have cancer, that they have some type of very rare disorder, even when they don't. Mixed delusions can describe a person who has different types of delusions. Perhaps a person with grandiose delusions, and because of their high stature, they also believe that people are trying to persecute them. Delusional disorder is a disorder described unilaterally of having delusions that cause a person significant distress and are not due to another component or another diagnosis. So, for example, a person with schizophrenia who also has delusions would not have delusional disorder because the delusions are encompassed by the schizophrenia. Likewise, a person with bipolar disorder in a manic episode might have grandiose delusions, but they don't have delusional disorder often because the delusions only are occurring during their affective periods of mania. It's also important to understand catatonia and be familiar with this definition, not to be confused with Studio Ghibli's Cat Bus. It's estimated that around 10% of people with mental health disorders may have a psychomotor syndrome called catatonia. Catatonia was once considered a subtype of schizophrenia, but it's now recognized as its own mental illness that can overlap with other mental illnesses or be on its own entirely. The condition can cause psychosis as well as impaired motor skills and speech. It's important to note that the first-line treatment for catatonia being a period of meaningless and profound inhibition, is to create a double negative. You inhibit the inhibitor through treatment with a benzodiazepine. So you can think of which benzodiazepines you might use, knowing the names of different benzodiazepines, lorazepam, clonazepam, but also being familiar with benzodiazepine medications that don't end in the suffix PAM, such as chlordiazepoxide and alprazolam, and being able to recognize those in a multiple choice environment to recognize that you just aren't looking for patterns, but that you truly understand and recall the names of different benzodiazepine medications. A conversation on psychosis would not be complete without discussing the role of substance use disorders. Substance use disorders as independent diagnoses will be covered in another pre-work section. However, misusing drugs or alcohol is strongly related to the development of many forms of mental illness later in life. There are also ICD-10 codes for substance-induced psychoses, which may occur during intoxication or withdrawal. That's to suggest that the substance is directly responsible for the psychotic symptoms, and the psychotic symptoms may resolve once the acute intoxication or withdrawal episode are completed. Another thing to note is that people in their early 20s or younger with substance abuse issues may be especially vulnerable to the development of psychosis, since their brains are still developing and have not finished myelinating. At this point, you may be asking yourself, what causes psychosis? And the easiest way to summarize is that there's not just one cause of psychosis. Genetics and neurotransmitter changes certainly are strong links. However, traumatic events, substance use, and underlying health conditions can sometimes lead to changes in the way the brain works or an underlying sense of inflammation that can result in further disruption. There are dopamine, serotonin, and glutamate disruptions that have all been implicated in certain psychotic disorders. However, there's not enough evidence to associate any one neurotransmitter disruption with psychosis. Quick spoiler alert, our typical antipsychotic medications or first-generation antipsychotic medications primarily work on dopaminergic transmission, while our atypical or second-generation antipsychotics work on dopaminergic transmission but also include some degree of serotonergic modulation. It is often grossly oversimplified that because our initial forays into antipsychotics helped with dopamine blockade, that it was thought that too much dopamine in the limbic system led to symptoms related to schizophrenia or psychosis. However, we know that the net explanation is not quite that simple, as so many other systems have been implicated. Psychosis responds to modulation of other neurotransmitters, and some of the best antipsychotic medications that we have don't work on dopamine much at all. When we acknowledge that psychosis can affect multiple neurotransmitter systems, it's no surprise that the symptoms likewise can be incredibly diverse. Psychosis can present with a wide array of abnormalities in thought and function, but the key piece is that it's often associated with an impaired perception of reality. That's to say, a person who's experiencing psychosis will have a different idea about their world around them, about what their senses are telling them, and the conclusions that they draw from that from people who do not have psychosis. Symptoms are listed here that range from difficulty concentrating, depressed mood, changes in sleep, anxiety, suspiciousness, social withdrawal, delusions, hallucinations, disorganized speech, such as switching topics erratically. Depressed mood, looks like I have that on the slide twice to emphasize that point, and thoughts of harm to self or others. Treatment for psychosis typically involves a combination of antipsychotic medications, psychological therapies, and social support. Now, if you have to choose one of those things, antipsychotic medications are almost always going to be the first-line treatment for a patient with psychotic symptoms. Why is that? Well, if a person is experiencing acute psychosis, it's unlikely that they'll be able to concentrate sufficiently to engage in psychological therapies, and likewise, it's difficult to accept social support if, for example, a person is too paranoid to accept those supports. Antipsychotic medications usually, but not always, work by blocking the effect of dopamine, in particular D2 receptors, and we'll go back and forth talking about typical or first generation versus atypical or second generation antipsychotics. I'm going to hold the learner responsible for knowing not only how the medication works, being able to identify which class of medication a medication is in based on the name, knowing what side effects that medication causes, as well as how to treat those side effects. Those are all second and third order applications that may occur in any of these cases that we look at for a patient with symptoms overlapping with psychosis. Let's also recall that benzodiazepines are used as inhibitory GABA-A agonists that help to inhibit the inhibition of catatonia. The diagram on the right of the slide breaks down that typical antipsychotics primarily affect D2 receptors as antagonists, whereas atypical antipsychotics have many additional receptors, primarily the addition of serotonin receptors or 5-hydroxytryptophan receptors in addition to the dopamine receptors. Now, typical antipsychotics have also usually been implicated for hallucinations and delusions, with, of course, a much greater effect on hallucinations, remembering that our definition of delusions is that they are fixed, whereas atypical antipsychotics have historically been implicated in treating more social withdrawal and some of what we would call the negative symptoms of schizophrenia. One way to conceptualize this is if we recall that our atypical antipsychotics include serotonergic modulation, and we know that serotonin is involved in mood, we might expect some additional changes in a person's mood or motivation as a result of being prescribed an atypical or second-generation antipsychotic. Now that we understand psychosis a little bit better, we should definitely talk about schizophrenia. Schizophrenia, as we mentioned, has very much overlapping symptoms with brief psychotic episode and schizophreniform disorder. However, this is when symptoms have persisted for at least 6 months. Schizophrenia, many consider to be the hallmark of psychiatry, and it's arguably one of the disorders that my non-psychiatrist colleagues have the most trouble with treating. Schizophrenia is, because psychosis and thought disorder are the pivotal parts of schizophrenia, it can be characterized as a disorder in which patients interpret their reality abnormally. It may result in some combination of hallucinations, those are the perceptual disturbances, delusions, the fixed false beliefs, and extremely disordered thinking and behavior that impairs daily functioning. Schizophrenia affects about 1 out of every 100 people, and the age of onset is usually in the teenage or years or early 20s for men, a little bit later for women, usually age 23 to 35. Almost everybody diagnosed with schizophrenia is between 15 to 55 years of age. It's very unusual to have somebody with schizophrenia diagnosed outside of those age ranges. So we look at other diagnoses if it's a child or a geriatric patient. Schizophrenia is more common in men, and people with schizophrenia have a higher mortality rate from natural causes and die on average 20 years earlier than the general population. Why is that? Imagine if a person has differences in their reality, their insight about their conditions, about their health, about their safety, are going to be much less than a person who has good insight and who's has a good understanding of reality. Patients with schizophrenia have a high incidence of substance use disorders. Part of that may be in order to treat some of the symptoms, so to speak. There is some inequity in that it is diagnosed more frequently in Black patients, and about 90% of those with schizophrenia historically have smoked tobacco. One of the thoughts for this is that nicotine receptors, when those are stimulated, may reduce some of the positive symptoms and may also improve some of the cognitive impairments. We're not recommending that any of our patients go and smoke, but many of them do find smoking to be helpful on their own. Now, throughout this talk, I have alluded to the diagnostic criteria for schizophrenia, but we haven't spent a lot of time on them. If this is your first exposure to the DSM-5, or the Diagnostic and Statistical Manual of Mental Disorders, you'll notice that a lot of the criteria read a little bit like this. They say that there should be this many symptoms for a certain amount of time. So in the case of schizophrenia, we're looking for 2 or more of the following symptoms for at least 1 month. And one symptom should be either delusions, hallucinations, or disorganized speech. There should be trouble functioning in work, relationships, or self-care since the onset. And again, that the signs of the disorder are present for at least 6 months. Some of the ways to think about this are if you have a person who has only negative symptoms, they're not going to meet criteria for schizophrenia because they don't have symptoms in areas 1, 2, or 3, and they also don't have 2 or more of the following symptoms. While memorizing DSM-5 isn't necessarily the goal of the course at this level, you should be aware of general symptom areas and how to classify and categorize these symptoms. For schizophrenia, there's at least 2 major clusters of symptoms, being positive symptoms and negative symptoms, and some literature also talks about disorganization symptoms, which personally I tend to group with the positive symptoms. A way to remember this is the positive symptoms aren't called positive symptoms because they're great or positive things, but because they are the things that we most commonly see. When we see a person, for example, I was driving earlier today, and I was in a parking lot outside of a grocery store, and there was a man outside who was shouting to himself. He appeared to be what we would call responding to internal stimuli. Perhaps he was having hallucinations. Perhaps he was also having delusions that somebody might have been out to get him. Those types of things that others can easily see and hear, perhaps, and the things that people that tend to scare the general public when they see somebody with these symptoms, those are the positive symptoms. That's different than the negative symptoms. Negative symptoms often start with the letter A, avolition, or a lack of volition or desire to do things or to move. Alogia, a lack of logos or speech. Anhedonia, a lack of hedonism or joy. Blunted affect, and asociality. And then the disorganized symptoms, as I mentioned, disorganized behaviors can be behaviors that look very unusual, and disorganized speech might be connecting words or ideas together in a way that doesn't really make sense for somebody else to understand. Again, I lumped the disorganized symptoms as positive symptoms because those are things that I can see or hear another person doing. Now, I did mention that the positive symptoms often might be the things that others notice and the things that might scare people when they see somebody with severe mental illness. It is worth noting as an advocate for people with mental disorders that it is much more likely that a person with severe mental illness is going to be the victim of a crime than to be the perpetrator of a crime themselves. One of the reasons for that is meaningful crime takes planning. It takes proper executive function and the person's ability to use their frontal and prefrontal cortices to plan and to do things. Now, of course, anyone can defend themselves, but again, a person with severe mental illness is unlikely to be able to execute the degree of planning that's required to carry out some of the more complex acts involved with violence or taking advantage of others. If you didn't get the message earlier, this is again just another slide that breaks down some of the disorganized symptoms as part of positive symptoms, as well as negative symptoms, referring to an absence of things that we might find in a person without the severe mental illness. This is just another slide to get a better idea of what these positive and negative symptoms are and to become more comfortable with being able to categorize them and identify them. Likewise, this is a slide that takes a look at breaking down the negative symptoms into more definitions. I'd encourage you, if you want, to pause the slides here, take a look, get comfortable with the different words for negative symptoms, especially if these are words that you're not too familiar with, or if you didn't study Latin previously to understand some of the roots of these words. I'm not going to go through and read you the definitions, but spend as much time here on the slide as you need to better understand these things. Similar to psychosis, theories on the causes of schizophrenia are multifactorial. There are genetic causes. For example, monozygotic twins have schizophrenia more commonly than dizygotic twins. There may be viral factors, in that more people with schizophrenia were born in the winter. There are also social factors related to social causation, perhaps related to dense living environments, prenatal factors, neurochemical irregularities, lead exposure, many different factors. Schizophrenia can also disrupt interpersonal relationships and diminish the capacity to work or live independently, and these deficits lead to a cycle of further functional impairment, as people are less supported in their relationships, struggle with housing and employment. People with schizophrenia have significantly increased rates of suicide and, as mentioned before, higher rates of earlier death. They may have a lack of emotional expressiveness and inappropriate or flat emotions that correlate with the negative symptoms. They may have disturbances in their movement or behavior, as well as, but not always, a disheveled appearance. If we were to look specifically at genetic factors, schizophrenia is genetically heterogeneous. It is not likely caused by a single gene. Family studies do show that relatives of someone with schizophrenia are at increased risk of also having schizophrenia, and specifically negative symptoms have a stronger genetic component. I had mentioned some of the details on monozygotic twins versus dizygotic twins with more information on the slide. Children of Children of the monozygotic twin without schizophrenia were also more likely to develop schizophrenia, indicating that there may be causal factors or factors related to, say, allostatic load that may cross generational barriers. Adoption studies also indicate that there is an increased likelihood of developing psychotic disorders if a person had relatives with psychosis or schizophrenia. Some developmental factors to keep in mind is that the prefrontal cortex usually matures in adolescence or early adulthood, which corresponds with the time, particularly in males, when schizophrenia makes itself known. Dopamine activity also peaks in adolescence. We know that stress activates the hypothalamic pituitary adrenal axis, which triggers cortisol secretion, and increased cortisol increases dopamine activity. Schizophrenia may also be felt to be due to excessive pruning of synaptic connections versus, say, a diagnosis like autism spectrum disorder, which is often correlated with insufficient pruning of synaptic connections during brain development. There are also significant studies relating that the use of cannabinoids during adolescence were associated with increased risk. This may explain why some symptoms appear in late adolescence, even though brain damages can occur early in life. There's also some data to suggest that stress can increase the risk of a person developing schizophrenia. Individuals with schizophrenia and their first-degree relatives have greater decreases in positive mood and increases in negative mood related to the stressors they experience. We also notice that the highest rates of schizophrenia are among those who live in urban environments as well as those who live in poverty. There is a sociogenic hypothesis saying that the stress of poverty, and poverty is quite stressful, increases the risk of the disorder, as well as a social selection theory suggesting that a downward drift in socioeconomic status leads to stressors which further pose a risk of developing schizophrenia. Environmental factors may also play a role. For example, obstetrical complication rates are high in infants who later develop schizophrenia. There's a possibility that the reduced supply of oxygen during delivery may result in insults to cortical matter and resultant loss. There's also an association with viral damage to the fetal brain, in particular the presence of the parasite Toxoplasma gondii, which was associated with a 2.5 times greater risk of developing schizophrenia. Also, a Finnish study reviewed identified that schizophrenia rates were highest when the mother had influenza in the second trimester of pregnancy. This slide reviews some of the environmental factors we've already spoken about, including prenatal exposure to viral infections, poor prenatal nutrition, adverse obstetric events, and cannabis smoking during adolescence. This is a little bit of a busy slide, and for our purposes, I honestly wouldn't worry too much about the specifics that are listed here. The goal here is to point out, not surprisingly in an osteopathic psychiatry course, that structure and function are intricately related even in the course of mental disorders such as schizophrenia. We'll talk a little bit more about this later, but we do see that as we have cortical degradation and a decrease of the solid parts of the brain, we do have a corresponding increase in the size of the ventricles. We also have changes at the cellular and neurotransmitter level where we have various increases and decreases related to different neurotransmitters. Again, at this stage, I wouldn't worry too much about specifics here, but if you choose to go into psychiatry or neurology or cellular biology, then perhaps this is something that might be of greater interest to you. Similarly, here on my assessments, I'm not too worried about asking you specifically about genetic influences here. However, as you go through medical education, you should be aware of single nucleotide polymorphisms in genes that show up a number of places, such as in COMT or BDNF, and how those can be associated with multiple systemic changes, in this case, schizophrenia specifically. I think the bigger takeaways from earlier in our discussion in saying that the causes of schizophrenia and psychosis in general are very heterogeneous and can come from many different areas. As we discussed earlier, neurotransmitters are key to some of our understandings of schizophrenia, but they don't explain the whole picture. The dopamine theory is probably the longest lasting theory related to some forms of psychosis and schizophrenia, and it makes sense. Excess levels of dopamine can cause psychotic symptoms. Drugs that reduce dopamine activity, such as our first generation or typical antipsychotics or neuroleptics, the gold standard, for example, being haloperidol or Haldol, can decrease psychosis, whereas amphetamines, which increase dopamine levels, can induce psychosis. I highly recommend going to watch Breaking Bad if you need more education on amphetamines with relatively low risk. However, this theory, of course, has been revised. We know that perhaps instead of having just too much dopamine, maybe it's that there's too many dopamine receptors, or maybe they're too sensitive. And those dopamine receptors are primarily located in the mesolimbic pathway. Mesolimbic dopamine abnormalities relate to those positive symptoms that tend to respond pretty well to our first generation antipsychotics. There may also be underactive dopamine activity in the mesocortical pathway, and perhaps that's related more to our negative symptoms. Likewise, medication side effects in the nigrostriatal pathway lead to movement disorders. Now, I wouldn't gloss over the slide just because it has dopamine pathways and things that perhaps give us some flashbacks of neurology class, but I would spend some time specifically thinking about which of the dopamine pathways are responsible for different symptoms as they relate for a person with schizophrenia. The dopamine pathway, of course, not listed here is the tuberoinfundibular pathway, and that one is associated with the risk of lactation or gynecomastia, particularly on patients taking the second-generation antipsychotic risperidone. This slide reviews some of the material that we've already discussed, saying that in schizophrenia, perhaps an injury, whether it's due to cannabis use or inflammation or perinatal factors, to the prefrontal cortex that can result perhaps in overpruning of neurons there, is also associated with dopamine neurons being underactive in that prefrontal cortex or in the mesocortical pathway. We had mentioned that that's associated with the negative symptoms of schizophrenia, whereas an increased release of mesolimbic dopamine in that pathway is associated with the positive symptoms of schizophrenia. So I want to make it clear that schizophrenia is not simply too much or too little dopamine, but rather it depends on where that dopamine imbalance is occurring and how that affects the patient. Not all patients with schizophrenia specifically have all positive symptoms or all negative symptoms. It's often a combination thereof related to general dysfunction in areas that are dopaminergic in nature. These two side-by-side images again give us an idea of a sagittal look at the brain. I particularly like the reminders of the different areas and anatomy, the neuroanatomy that's associated with the dopaminergic pathways. I want you to be responsible again for all 4 of the dopaminergic pathways that are listed: mesocortical, nigrostriatal, tuberoinfundibular, and mesolimbic, and be able to describe how these dopamine pathways play a role both in the symptoms, treatments, and side effects as we conceptualize everything that has to do with schizophrenia. Now, as we previously mentioned, the dopamine theory does not completely explain schizophrenia. Sure, antipsychotics block dopamine rapidly, but maximal symptom relief actually takes several weeks, so it's not just about blocking the dopamine. To be effective, antipsychotics must reduce dopamine activity to below normal levels, and that's associated with various side effects that we'll explore in more detail. You'll also get in your pharmacology lectures associated with this course. And if we really want to mix things up, one of the most effective antipsychotics, clozapine, goes by trade name Clozaril in the United States, has very little relative effect on dopamine. Interestingly, another antipsychotic medication that ends in PINE, quetiapine, it has very similar low dopaminergic activity, which allows for its use in psychosis for patients with Parkinsonism. Borrowing from my earlier lecture in neurology, we can think about why we would not want to block too much dopamine in patients with Parkinsonism, or how using a dopamine blocker like haloperidol would worsen a person's Parkinsonism and or extrapyramidal symptoms. Other neurotransmitters are certainly involved, and we've seen them on the slide: serotonin, GABA, glutamate. There is some increased evidence that medications that specifically target glutamate may be of greater utility in the days ahead. We see more correlates here from neurology, in that for patients with schizophrenia, we will often see enlarged ventricles, and that implies a loss of brain cells, a loss of cortical cells, and that correlates with poor performance on cognitive tests, poor premorbid adjustment, and poor response to treatment. Going back to neurology, remember that there are other disorders that demonstrate this area of shrinking cortical mass. In particular, we saw that in several of our neurodegenerative diseases, and in particular, Alzheimer-type dementia. From neurology, we may recall that the prefrontal cortex is associated with some of our highest order thinking. You might be familiar with differentiations between the dorsolateral prefrontal cortex, the orbitofrontal prefrontal cortex, and the ventromedial prefrontal cortex, some of which are also covered other areas in this course. For the purposes of understanding schizophrenia, I just want you to understand that areas in the prefrontal cortex are disrupted. Ideas such as speech, decision-making, these things that happen in the prefrontal cortex end up being interrupted. And individuals with schizophrenia show impairments on neuropsychological tests that specifically address the prefrontal cortex, such as memory and executive function. We do know on functional imaging that individuals with schizophrenia show low metabolic rates in the prefrontal cortex, and some frontal activity is actually decreased quite a bit in the area of negative symptoms. We also know that there is a loss of dendritic spines that results in disrupted communication neuron to neuron. More structure-function associations in the temporal cortex. That, of course, holds the temporal gyrus, the hippocampus, the amygdala, parts of the anterior cingulate. And I'd like you to reflect on how disruptions in each of these areas corresponds with some of the clinical and behavioral abnormalities that we've discussed, such as problems with emotions or auditory processing. We see reduced gray matter and volume changes in these areas, again suggesting disrupted connectivity and decreased function in these areas in patients with schizophrenia. In this course, we're going to spend a lot of time talking about medications, in particular the antipsychotic medications, because they're associated with such profound effect, but also such dangerous side effects that need to be monitored. So our first generation or typical antipsychotic medications, also referred to as neuroleptics, generally fall into the categories of the phenothiazines, the butyrophenones, and the thioxanthines. These medications primarily block dopamine at the dopamine 2 receptor, and they're responsible for reducing agitation, violent behavior, and really a focus on those positive symptoms. However, in blocking dopamine, we also have extrapyramidal side effects. Now, the extrapyramidal side effects can include acute dyskinesias, akathisias, tardive dyskinesia, and neuroleptic malignant syndrome. Each of these areas for medication side effects is something we'll explore more in our in-person class, but some ways just to kind of think about them and conceptualize now is an acute dyskinesia is exactly what it sounds like. It's a muscle or a movement disorder that occurs acutely in response to a medication. This is different than a tardive dyskinesia, which develops usually over time and is lasting even after the medication is discontinued. Acute dyskinesias are generally treated with anticholinergics and occasionally antihistamines. Akathisia is a sense of inner restlessness, and it's primarily treated with a beta blocker. Tardive dyskinesia, which I contrasted from acute dyskinesia, is generally treated with our VMAT2 inhibitors, not with anticholinergics. Long-term exposure to anticholinergics can actually make tardive dyskinesia worse. Neuroleptic malignant syndrome is a medical emergency, and that will be discussed more in our pharmacology lectures that correspond with this course. Now, our second generation antipsychotics, also known as our atypical antipsychotics, certainly do often affect dopamine like our typical antipsychotics. However, these newer second generation medications also primarily impact serotonin or 5-hydroxytryptophan receptors, and that's one of the things that set these apart. They do affect other receptors as well, but for our purposes, again, at this stage in your training, I'd like you to think of atypical antipsychotics as affecting both dopamine and serotonin. Clozapine or Clozaril is a medication that I promise you are going to be tested on and see in your careers. And with clozapine, the risk of agranulocytosis is higher than any other antipsychotic medication. A question might typically be, what labs would we use to monitor this? And you might think, well, agranulocytosis has to do with granulocytes, which are white blood cells. But specifically, agranulocytosis refers to neutrophils. So possible answers might include the white blood cell count, the absolute neutrophil count, or the percentage of neutrophils, all as ways that we might assess how a person is doing if they are on clozapine. Our second generation antipsychotics have fewer motor side effects because they're not as heavy on the dopamine blockade, and there's also less issues with treatment non-adherence. Because of that, it reduces the risk of relapse as patients are more likely to take medications that they don't hate taking. Now, side effects, as noted from our second generation antipsychotics, you notice that I've bolded increased metabolic side effects. Now, that can include anything that's associated with metabolic syndrome. So ways that we might assess that or monitor that for a patient can be things like taking their weight, their abdominal circumference, looking at fasting lipids, looking at fasting glucose, looking at a hemoglobin A1C, or monitoring blood pressure. Less commonly, second-generation antipsychotics can be associated with impaired immune system functioning, seizures, dizziness, fatigue, sedation, or weight gain. And there is some suggestion that newer medications may improve our cognitive function and negative symptoms. But from the research, the jury's still largely out on this as a class. This is a slide that I'm not going to spend a lot of time on, but I would like you to spend a lot of time on it. Specifically, you are responsible for knowing all of these generic names of medications, being able to then make the second order distinction of putting them into a category of, say, looking at chlorpromazine and knowing that that is a first generation antipsychotic. You do not need to know the trade names for the purposes of our course, but you will see them out in practice. So if you can learn them, that's a secondary and optional thing to learn. So again, you should be able to see a drug name, link it to a category of drug, and then in particular know what side effects and how you would monitor it. For example, if you see a question for a patient on risperidone, I would expect you to be able to make the cognitive link that that is a second-generation antipsychotic. Because it's a second-generation antipsychotic, I'm primarily concerned about metabolic side effects. And in a patient taking risperidone, I would be interested in monitoring things like their weight, their waist circumference, their blood pressure, their fasting lipids, their glucose, and so on. With risperidone in particular, I would also want you to know about the somewhat novel but not unique side effect in that it can disrupt dopamine transmission in the tuberoinfundibular tract, relating to gynecomastia in men and lactation in both men and women who take that medication. You should be familiar with some of the outcomes of the CATIE, or the Clinical Antipsychotic Trials of Intervention Effectiveness Study. In the study, second-generation medications, or our atypical antipsychotics, were not more effective than the older first-generation medications. And interestingly, the second-generation medications didn't necessarily produce fewer unpleasant side effects. And there were many, many patients that stopped taking the medications before the study ended. The takeaway from this is, even though we generally in this decade in the United States, we generally avoid typical antipsychotics, especially in younger patients and as first-line agents, because we perceive them as having more serious side effects, we do have problems with our second-generation atypical antipsychotics as well. Things we've mentioned: weight gain, a risk of diabetes, pancreatitis, increased risk of hypertension, coronary artery disease, cerebrovascular events, and other cardiometabolic sequelae. In general, these medications are unpleasant to take, and especially for a person who has enough insight to remember to take their medicine, they also may be aware of some of these side effects and not want to take them. There are a number of mechanisms that we might use to help a person increase adherence to their medication and then their function and safety, while also minimizing these side effects as much as possible. I do also note a disturbing trend here that people of color in the CATIE study in general were not prescribed second-generation antipsychotics as the same frequency as other patients. Earlier in our discussion, I had mentioned that the primary treatment for psychosis and for schizophrenia is going to be our antipsychotic medications, remembering that it's difficult to go to therapy if one does not have the focus or cognition to engage in therapy. It's also difficult to trust a therapist if one is paranoid. However, significant studies have suggested that medication plus psychosocial interventions have been effective. In particular, cognitive behavioral therapy, or CBT, to identify target problems or symptoms and build coping skills to address them can be particularly helpful. Social skills training can also be useful, such as teaching skills for managing interpersonal situations, like completing a job application or reading bus schedules or making appointments. So this is to say that if you are the physician or working with a physician who's treating somebody with schizophrenia, the medication often isn't enough. Many of these patients need additional assistance in psychosocial parts of their life, as well as in their relationships. Family members and partners can be particularly helpful to educate, to manage expressed emotion, and to help them better understand the causes, symptoms, and signs of relapse. Stressing the importance of the medication. The person you're living with and that you care about might not like taking this medication, but it is really important, and the best way for them to take less medication is actually to take their medication every day and now, or to get on one of the long-acting injectable medications that only needs to be given every 2, 4, 12, or even more weeks. So we do have these long-acting versions where a person doesn't need to remember to take their medication every day, and those can be incredibly helpful. We want to work to improve family communication and problem solving, expand support networks, and perhaps most importantly, instill a sense of hope. One organization that I particularly like working with is NAMI, that's N-A-M-I, or the National Alliance of Mentally Ill, and they provide terrific family resources, as well as education in the communities. We had already talked about cognitive behavioral therapy, or CBT, as a potential option, including recognizing and maybe, if a person's ready for it, challenging their delusional beliefs, recognizing and challenging the expectations associated with negative symptoms, such as engaging in things to help with mood or speech or activities. Cognitive remediation training, CRT, or cognitive enhancement therapy, CET, can work to improve attention, memory, problem solving, or other cognitive symptoms. Case management can be critically important, providing a multidisciplinary team to provide comprehensive services. One of the teams that I work with is in patients in California who have conservators. That's other people, often a public guardian, sometimes a family member, who helps them with making decisions related to their medications, related to their estate, all of those things. And on that team, we have several case managers that are absolutely outstanding for helping connect the dots with housing, with funding, with resources to help people manage as best as possible. Noting again that many patients, not all patients, but many patients with schizophrenia really do struggle with function. And finally, residential treatment and vocational rehabilitation. This concludes our discussion on thought disorders, psychosis, and the time that we focus specifically, of course, on schizophrenia. I hope this conversation has been informative for helping you have a better understanding at a second-year osteopathic medical student level to help you better understand these topics, and perhaps most of all, to help you better empathize with the patients who suffer from these disorders. These disorders can be highly disabling and impairing. However, there are opportunities for considerable strength and growth, family opportunities, and helping people really improve their function, so long as one best understands the diagnosis, the treatment, the risk factors, and potential outcomes related to these disorders. Thank you for your time. Have a wonderful rest of your day.